which is what we are doing right now, and it will continue. We have an education arm, which consists of a few different things, which we'll go through later. And finally, the start of the Paedengage program, which is really the referral of patients when needed. Next slide, please. As part of our engagement, we had also conducted focus groups, needs analysis with various GPs across the country. This started sometime in 2018. A lot of it happened during pre-COVID. And during COVID and after COVID, we had smaller sessions. And these are the various different PCNs and groups that we worked with. We have developed 3 different care pathways with lots of feedback from GPs. In fact, the different family medicine groups and the different hospitals helped us create them. And we had lots of feedback, and thank you for all your feedback. And we'll be sharing these pathways with you later on. The enablement bit is really about the education, which is the e-learning modules. And besides the e-learning modules, we are also open to clinical attachments. So it should be 4-hourly clinical attachments at your own convenience, either at KK or NUH Children's Emergency, for which you can just email our contact emails, and we will arrange for these sessions according to your needs. Pretty much we want to just fulfill the needs of our GP partners. So whatever you're willing to see, whatever you're keen to see, we'll try our best to arrange for it, to make sure that we are really truly partners across both sides. We will also be having CME sessions every 4 months, and we'll let you know of that. And finally, from the 1st of April, partners who have completed the e-learning program can then start referring patients to us, similar to the GP Plus program. And this is expected to start next week. Shouldn't be a problem with the start date. Next slide, please. Quickly just introducing the team. Some of you have already heard from the different groups via email. We have been communicating. Both sides, KK and NUH, we have divided our teams into clinical education operations team and the comms team. And this is just a quick view of the teams. This from KK. The next slide. This is our team from NUH. Next slide, please. Okay, here I'll be handing over to Dr. Jasmine, who will be taking on the next part of the presentation. Over to you, Jasmine.
Thank you, Sashi. So hi, everybody. I'm Jasmine. I'm the lead from NUH for Paedengage. I'll just take you through a couple of slides now about what it is becoming a Paedengage partner. So I thank you all for registering your interest to join our program. But I'd like to emphasize that we have to complete the e-learning modules, and then we can officially certify you as a Paedengage partner for you guys to then refer on your patients to CE to get the $50 discount. So this is basically to sort of give us all clear ideas of the pathways that we're using, and also just to revisit some of the basic PEDS knowledge that we can all have a common understanding as well. So once you have completed the modules, what you will then expect to receive through the mail will be a package consisting of, number 1, the hard copy referral booklet. There's a carbon copy and for yourselves, and then the original copy, which then goes with the patient and comes to the emergency for their referral. There will also be a decal that you can display at your clinics for recognition. Some posters as well for patient education, and some referral brochures as well. Other things that we can send through the email will be the 3 care pathways that we will talk about during the webinar later on. You can print it out and put it on as a hard copy for your own reference in clinic, or you can keep it as e-copies. And also the certificate of completion of the e-learning modules, which we will also send via the email. Next slide, please. So this is just some pictures of what you're expected to receive in this package. So on the left, the decal, the poster in the middle, which is A4 size, and some of the patient brochures that you can give out in the clinics as well. Next slide, please. So this is the e-learning certificate completion that will be emailed across after completion of the e-learning modules. And after completion, then we will actually officially recognize you as a GP partner for Paedengage and take on your referrals from the GPs. Okay, so just talk about the workflow of how the referrals can take place. So obviously, if you see any pediatric patients in your practice and you decide that a referral to CE is required for further management of the child, the physician will then have to fill up a referral form, and please advise the parents to bring their child together with the hard copy form to the nearest children's emergency, whether it's NUH or KK, within the next 12 hours. The patients will then be triaged accordingly in the children's emergency, but we will attempt to see the referred patients under the Paedengage program as soon as possible. GPs will also be provided with feedback later on, as we'll be doing a continual audit process to look at appropriateness of referrals. This will be on a regular basis, and then we can sort of streamline and some of the referrals that we receive from you guys as well. And to follow up in terms of closing the loop with GPs, patients may then be advised to return to the referring GPs with a memo for any continuation of care, for example, for chronic illnesses, or to manage after the acute illness has been managed in the children's emergency. And with time, I think the overall aim is to implement direct referral pathways to our pediatric subspecialty clinics for long-term follow-up. But this is still a work in progress, and we will update you guys further once we finalize the details for this. Next slide, please. Thank you. Okay, so just to look through the actual hard copy referral form, again, we want to emphasize the need to pass on the hard copy form, as this is what we will be looking at and collating at the children's emergency level for all patients that are referred in. In the red box, the date and time is required, and please also indicate the closest children's emergency to refer to, and also fill in the details as per the form. Next slide, please. Okay, so I think now what we'll do is we're going to introduce our 3 clinical care pathways to you guys to briefly go through some of the things that we touch upon. And these also constitute of certain workflows that might be useful in a clinic base. So it's because we understand some of the e-learning modules may be more content-based and it will be easier to work on a workflow basis. So we'll just quickly talk through these ones, and I'll start by looking at the fever pathway. Okay. Okay. Hold on, let me share my screen. Okay, I hope that everybody can see my screen. Please let me know if you can't. So I'll briefly talk about the first pathway, and that is for the referral of pediatric fever, which encompasses a lot of, actually the majority of the illnesses that you see in pediatrics in the community, as well as in the children's emergency. So just a brief outline. The first box, again, is to decide whether or not this child is a sick child. If you have unstable vital signs or a toxic-looking child, please call for an ambulance for prompt transfer to the children's emergency for further management. The second big box will be those children that are stable, but who do need some management that are outside of the scope of general practice. Or if you do have a limitation of resources, for example, if you don't offer blood tests or urine tests, for example, then we can actually refer on if so. So we did try to encompass as many conditions as possible. For example, the infantile pyrexia age, so any fever more than 38 degrees in children less than 3 months old, hyperpyrexia, the high-risk children, or prolonged fever more than 5 days. Again, if there's undifferentiated fever more than 3 days, and if you do not have any full blood count facilities, then you can refer on as well. And obviously certain conditions that require further management or even inpatient admission, such as suspected Kawasaki disease or young children with UTI, or signs of other more serious conditions that are not responding to oral antibiotics in the community, such as if you have any complicated pneumonia, soft tissue cellulitis infections, or even like some lymphadenitis are not responding well. Okay, the sick ones at the meningitis or non-blanching rash, all this, please also refer in to us. Okay. Then the third box usually is basically an outline of the conditions that we think may be well managed in the community. For example, the short duration of fevers, less than 5 days. And if the child is actually not dehydrated clinically well, they can be managed with symptomatic treatment. And some outpatient antibiotic oral treatments can also be utilized in these groups of patients. So the older children with urinary tract infections, otitis media, pneumonias, and are actually clinically and functionally well. We then also include certain appendices in the fever guidelines. So the first appendix will be actually hopefully a useful guide for pediatric vital norms that you can have in your clinics for ease of reference according to the age group of the patients. Second appendix will be our suggested outpatient management for first episode of uncomplicated pediatric febrile urinary tract infection and how urinary samples should be collected for an accurate diagnosis. And our suggested treatment with first-line empiric antibiotics. Then going on, third appendix will be that of our suggested outpatient management for mild community-acquired pneumonias in the older child more than 2 years old and who's clinically well. These can be managed with oral antibiotics, such as amoxicillin or clarithromycin, azithromycin as suggested. But if you do have X-ray facilities and you do have lobar pneumonias or certain degrees of respiratory distress, please do refer them in as suggested. And our last appendix for the febrile conditions will be that of outpatient management of ear conditions. And again, these are suggested pathways that you can follow, but obviously do what is common for you in your own GP practice and what you have in your formulary as well. Okay, so this is the end of the first fever pathway. If you do have any questions, please drop them in our Q&A. We can answer them later on at the end of the session. And I'd like to hand over the second clinical pathway, so a child with breathlessness, to Dr. Li Ying, and she'll take you through the rest. Thank you.
Okay. Yeah, so sorry, just now I was muted. So I'm going to start from the beginning again. So I'm Li Ying, and I'm going to go through the pediatric guideline for respiratory for children with breathlessness and also the threshold for referral to children emergency. Yeah, so here in the first box, mainly it goes through the type of children who should be referred to children emergency immediately. So those with hypoxia and also any significant features of respiratory distress as listed here, and also any abnormal vital signs in terms of tachypnea, tachycardia, any signs of poor perfusion, and also any signs of upper airway obstruction in terms of their position of comfort, as well as any abnormal stridor. Also features of anaphylaxis, poor perfusion, and also young children with any apnea or cyanosis need to be promptly referred to children emergency. And we have also included here for those who are in significant severe respiratory distress, while waiting for the ambulance, there's a guideline here to follow for what to administer according to what you have in your clinic, as well as we understand that not every clinic carries nebulizer or MDI. Then next, also, those with significant past medical history or immunocompromised or children with congenital histories should also be referred to children emergency. So these children can be managed as outpatient if vice versa they don't have any of the abnormal signs that I mentioned above just now. Then in the appendices, we have included the outpatient management for 4 types of conditions in terms of respiratory illnesses, namely asthma, bronchiolitis, croup, as well as pneumonia. So for mild asthma, it can be managed outpatient according to our recommended treatment here. If they have mild asthma, you can trial salbutamol as well as oral PrEP and look for response. If there's no response or if they are still significantly having respiratory distress or abnormal vital signs, then they should be referred to children emergency. And we also included if they are fit for home, what to prescribe and what to do in terms of follow-up as well. So we should provide them with a written asthma action plan, which we have also included here. You can fill it up and give it to the parents, and so they have a guideline to follow when the children are unwell. Then as well as the next one would be a mild bronchiolitis for children less than 2 years old. If they are quite well, no abnormal vital signs or no significant respiratory distress, they can also be managed outpatient according to our management guideline here. For mild croup with croup score of less than 2, they can also be treated outpatient with a low dose of oral dexamethasone and review. If the croup score is still significantly at 2 or more than 2, they should be referred to children emergency. And lastly, for the community acquired pneumonia, similar to what was mentioned earlier on, if they are non-toxic, non-hypoxic, and with just very mild respiratory distress, they can be managed outpatient with oral antibiotics as well. So the next one would be Dr. Anu. She will be going through the pathway for gastroenteritis.
So hi everyone, my name is Anu. I'm from KK Hospital. So I'll be taking us through the next set of guidelines, which really is for the management of child with vomiting or diarrhea. So with any child with vomiting or diarrhea, the first box really goes back to the goals of assessment, which really is identifying the child who is dehydrated and also the assessment of the degree of dehydration. There are certain risk factors as well, such as the age and the feeding of the child, as well as any existing comorbids, especially if they have underlying renal or GI pathology, and in the absence of any reliable caregiver, then these would all warrant referral to the children's emergency. Also important to recognize that vomiting really is the first presenting complaint of a variety of conditions. Also to think about some of the possible differentials in terms of the presenting child in front. So in terms of referral guidelines, again, going back to any child with unstable vital signs, if there's any concerns about a toxic looking child, or if there's any concerns of moderate to severe dehydration, and presence of any high risk factors that were identified as above, and if there's any underlying concerns of a surgical abdomen or any underlying disease processes such as myocarditis, meningeal encephalitis, or DKA, then all these would warrant an urgent referral to children's emergency. But by and large, most children with GE really can be managed at home with oral rehydration therapy. Some of the suggestions in terms of patient criteria, in terms of monitoring at home with oral rehydration, we've highlighted some of these. And we've also recommended some possible discharge medications for the common for the common presenting complaint of GE as well. Again, we would advise our GPs not to discharge any children with any antiemetics or antihistamines just for the purposes of stopping the vomiting. And if the child continues to have persistent vomiting, then again, we would recommend that we will advise the parents to come to any one of the children's emergency. So in terms of the appendices, the first one really just goes through some of the key things to look out for in assessment of the degree of dehydration. And finally, as well, going back to some of the triage guidelines in terms of the vital signs that are like within normal limits for the different age groups. So then in terms of apart from the clinical pathways, some of you would have already started on, some may have already completed some of these e-learning modules. As Dr. Sashi had shared earlier on, a lot of these modules were also based on some of the GP's feedback in terms of some of the common conditions that present to your clinic and what were some of the common conditions as well that you wanted some amount of revision on. So based on that, then we curated these 8 different learning modules. Of course, in terms of the guidelines and recommendations that were highlighted in the slides really were based either on our practices within our hospitals or also based on, guidelines that we would have come across in the literature. Part of the e-learning modules also was the assessment in terms of how well you have covered the topics in terms of the MCQs at the end of the modules. And then this also would have accumulated in a summative and final MCQ assessment at the end of all 8 modules. As mentioned, once you have completed successfully these learning modules, then we also award you with a certificate of completion. So in terms of other possible resources that will be available for our partners, apart from the clinical pathways that we will send out to you, as well as the e-learning modules, which ideally we would want our GPs to complete within a 2-month period, we will be also looking to set up a WhatsApp chat group for those of you who have successfully become our partners. So we aim to form this at the start of next week. We will be creating 2 different chat groups so that you can be in touch with your CE partners depending on the location. And we will be using postal codes to also then demarcate the Western cluster, which we tag to NUHCE, and then for the rest of Singapore to KK Children's Emergency. We will operate on an opt-out system. So if any one of you are not comfortable with being part of the WhatsApp chat group, then just please drop us an email and then we will keep you out of the chat group. We will also be looking to create observership opportunities within one of our children's emergency. The idea for these observerships really would be to come in and observe what happens in terms of anywhere from the triage process to attending P1, P2 cases. But again, because these are mainly observership opportunities, unfortunately, we won't be able to allow our GP partners to actively partake in the care of the child at that point in time. We'll also be looking to start 4 monthly case discussions and lectures in July of this year. So if you have any topics at the back of your mind or something that you are keen to for us to engage with you on as part of the first CME discussion and lecture, then please also email us to give us further guidance in terms of creating this topic discussion. And as of the end of next week, we'll also be looking to launch the website for our program by next Friday. So again, if you are not comfortable with your GP clinic being listed on our website, then just please let us know as well. Otherwise, all of you who have become our partners will then be also highlighted on our websites. So this brings us to the end of our presentation. I know some of us have already started asking some questions and having them answered within the Q&A. But this really is also a platform for you to address any other concerns or queries you may have had regarding the program. And I'll be happy to answer those questions.
Anyone have any questions, feel free to type it out. Let me quickly answer the question from Paul that I had said I answer live. Yes, Paul, you could use prednisolone syrup for croup as well. Dexa is the other option, but if you don't have Dexa, then prednisolone is fine. Yes.
Sorry, I got disconnected for a while. What we will do for the Q&A segment is perhaps we can go through the questions that were asked, and then there's some that we can answer live as well. And in the meantime, if you have more questions, you can keep them coming. So, okay. Thanks so much for the questions, Dr. Dr. Chuang, you mentioned that about a PDF of the e-learning modules, right, that we can send to you for reference. So yes, we will look into coming up with something that can be sent as a reference, or perhaps a summary. Maybe Anu or Ling, if you want to chime in for this part.
Sorry, Dr. Adila, I missed the question.
So Dr. Chuang is asking if we can have a PDF file of the online, I presume the e-learning modules that they can keep for reference. So maybe a way to refer back to the modules, or like he mentioned, a PDF copy of the materials, something like that. We can look into that.
Yeah, so
I think go ahead, Anu.
In terms of the sharing of the slides, I think we may not be able to share all of them, but definitely if we could just perhaps summarize the 8 modules and the key learning points.
Okay. And then Dr. Melvin asked about whether the materials are the same as the baby bear. So the e-learning modules are basically sort of a quick course on acute management of pediatric emergency conditions, whereas the baby bear is, if you look at it, is really about all conditions, including the chronic management. So it is quite different. But actually, Dr. Sashi did mention that for our e-learning modules, it's quite fast and quite easy to complete. So it takes about 15 minutes per module. Okay, and Dr. Paul asked about the WhatsApp group. Yes, so we will be setting up and starting a WhatsApp group for the KKH partners as well as the NUH partners. So for the Western cluster GPs, they will be under the NUH purview. So we'll have 2 separate chat groups so that we can, it's easier for our GPs to communicate with us. Yeah. So you do look out for that. Okay.
Adila, can I quickly answer a couple of questions that we have not answered by Dr. Mei Fang Hua? Dexamethasone is chosen as the first choice over prednisolone, mainly because it's been shown to reduce reattendances to the emergency setting when used slightly better than prednisolone. So for those who have dexamethasone, please go ahead to use it. If you don't have prednisolone as the second choice is still a viable option. And the dose is at 1 milligram per kilogram at a single dose. So I've put that up as well, just to quickly answer Dr. Mei Fang. And for croup, how long should you observe the child in your clinic before discharging? We would keep the patient for about an hour or so. And if there's deterioration or a person doesn't get better or continues to worsen, then you can bring them into refer them into the children's emergency. It may be difficult in your setting to actually keep them for an hour. So alternatives would be, if they're really unstable, to send them in to the emergency department. But if they're well, they can go home. They can always go home and do a follow-up call to check on them. So these are some of the options that have been used by different friends out there. Because different GP friends, partners have also asked this question before. Hope that helps. Thanks.
Okay. So maybe I will, since there are more and more questions coming, I will go to the questions that have not been answered and just go down the row. So do you know where to buy syrup on densitron? Okay, so maybe I open this to the children's emergency guys.
Yeah, sure. I can help there. Not easy to get syrup on densitron. We are working on bringing it in. At the moment, at least in KK, what we've been doing is using the IV form as an oral preparation off-label. It's been used for a very long time, for many years, and it's been okay. Regarding supplies, right, to be very honest, I think myself and Jasmine, what we would go back to do is look at all the questions that supply related, then we can compile answers and share with the partner. So if you have between KK and NUH, we can look at supply-related questions. We understand supply issues are a problem. So if you can work on that, we will do that and then get back to you. Is that okay, Jasmine?
Sure, yeah. As in from the NUH point of view, we are using tablets of densitron and crushing them and diluting. That's also another option because,
Yes.
as Sashi said, syrup or densitron is quite hard to come by, even in the tertiary settings.
Yes, we do that as well. We crush. So either we crush the tablets, split and crush, but sometimes the doses can go as low as 1 milligram for those at 1 year of age, right? Depending on their weight, etc. So sometimes we'd also use the IV preparation as oral. Yeah, but let's look at all these supply questions, and I think that's a very important part that I didn't really think about. We should work with our partners to see if you have any supply issues, what we can do about it.
Yeah, I think there are a few questions from I think Dr. Paul also, so we will consolidate all those together.
Yeah.
Okay.
I think, Adila, there's some questions on the e-learning.
Yes.
Okay, so what we have been doing is we have been trying to work through the batches of e-learning registration. We are very encouraged by the number of registrations from GPs. We have about 300 GPs who have expressed their interest to date, maybe slightly more than 300. So what we've been doing is that our e-learning platform guys are trying very hard to catch up with the creation of the accounts. So every few days we are setting up batch by batch. So I think we have almost 60% or 70% of the GPs who have registered so far have received the link for the e-learning. So you'll be getting it as soon as possible. Once you get it, you complete the e-learning. We will send you the materials as fast as possible. So you can only start referring really after completing the e-learning. I'm sorry for that particular point, but that's one of our requirements for our funding from MOH. So you do complete the e-learning and we will courier the decal, the referral form and the pathways all to you. And we'll also put you on the WhatsApp group the moment you complete the e-learning program.
Okay, about downloading the modules in PDF format and collating. I don't think there should be any copyright issue actually. Sashi or Jasmine, if you want to chime in.
Anu didn't know.
Anu is the
You probably
boss.
didn't know, right? You didn't know it could be done. No issues, right, sharing? Because technically, when you're using the e-learning module, you can screenshot also of the screen, etc. And quite a few people have done that. But if you can download the modules, that's perfectly okay. And we can. We're also working on the feedback that we received and trying to improve the modules. Thanks so much for all your feedback. We will keep working to improve the modules because we are also new in this journey, and this is really a journey we're very keen to work with everybody to move forward. So we will try to improve the modules along the way. And thanks so much for your feedback. Yeah.
Okay, from Dr. Andrew Chen, can the patient be referred to CE further away using Paedengage? So for a patient from Ang Mo Kio to NUH instead? Yes, of course. So the decision for which children's emergency they prefer is entirely up to the parent. But of course, we work based on whichever emergency is closest to the GP clinic. And that would be ideal. Yeah.
So MOH has asked that Western cluster GPs, Western GPs, or GPs in the Western part of Singapore refer to NUH, and then KK will manage the rest. And that's how the groups will manage. But at the end of the day, both our EDs, our children's emergencies, have patients from all over Singapore. And while, yes, we ask GPs to refer to one particular A&E, if they turn up in another A&E, we will honor the referral. There's no problem. We will not say, oh no, you must go to the other A&E or something like that. We are both working together in this, so we will honor all the referrals.
Yeah, it is a national program at the end of the day now.
Yeah, exactly. For PIDS GE, it's not recommended to send patients home with diaminoate syrup. We generally do not send patients home with antiemetics. Diaminoate particularly has not been shown to improve the outcome in terms of rehydration, in terms of stopping the vomiting, or even in terms of preventing reattendances. In terms of ondansetron, which is what we generally use, we don't repeat it because it's usually we try to stop the vomiting and then get them on a trial of feeds to get them to drink and rehydrate themselves. We also try not to mask other surgical problems that may come up from a child that's vomiting. So we usually do not send them home with antiemetics from the EDs. We do understand that the practice may differ in the GP setting. So you don't have to change your practice altogether, don't worry. But if there's persistent vomiting, as what most GP friends are already doing, please then send them in if there's persistent vomiting. Then we'll have to take over and manage. But I think what you have is
and just to add, the other thing is some of them are more prone to side effects, so like Maxalon and all that, even in the older kids. Okay, so that's what it is. Maybe Jasmine, you can answer the question on the UCCs.
Yeah, so I think the UCC in Bukit Panjang is doing quite well. We are looking at setting up second UCCs, but that's not any time close by because there's still a lot of work to be done on that. But yeah, that is something to look forward to soon now.
Okay, Dr. Chun-Fai Lee, as a GP, we have to keep up with changing COVID-19 management guidelines, various adult chronic guidelines for DM, hypertension, and so on, vaccinations. So a copy of the children emergency management guidelines will be very much appreciated. Dr. Sashi?
So what we have worked on a separate arm from this is also to create an education board, which is the Children's Emergency Guidelines. And I'm speaking on behalf of KK. I think Jasmine is not aware, but I'm sorry, Jasmine. I'll just go ahead to say this anyway. We have been working on putting our guidelines as a bot. And this is almost ready. In fact, it's supposed to be launched in April, but we pushed it because we are focusing on the Paedengage launch. So everyone will get access to this chatbot where you can go in and ask questions and refer to the guidelines. So we will put that up later on. It's just an innovation grant that we had. So we converted our guidelines to the bot. And the bot will answer questions on that. So that's going to be rolled out to everybody. Actually, anybody can use it. As long as you're a medical practitioner or a medical student or a nurse or a pharmacist, you can have access to that. So we will send out information on that later on. We'll work with our partners, our NUH team as well. And we'll see what we can do about that.
Dr. Ivan's question for Jasmine as well. About the Children's Emergency located at 10 Mile Junction. Is it a UCC? Maybe you can address that.
Yeah, so the 10 Mile Junction is Junction 10. That's where the current UCC at Bukit Panjang is located. At the moment, the referral for Paedengage is to Children's Emergency to get the $50 subsidy in terms of the back-end process for that subsidy. So unfortunately, not to UCC at the moment. But if you do have patients that want to come over to UCC, we are more than happy to accept, especially if you don't want to go to the hospital for whatever reason. Yeah, but we will not be able to give the $50 subsidy, unfortunately.
I presume this is the antimicrobial guidelines, is it?
So can we? I think we should be able to get an access to that, but that will also be part of the chatbot, Paul. So the thing is that it keeps getting updated very regularly. So let's see what we can do. If we can get our ID colleagues to share that, or alternatively, it'll actually be part of the chatbot. So hopefully we'll be able to get it from there. When the chatbot is launched, the materials will be there. Then if cannot, just email us and then we see what we can do.
Yeah. Along the way, if there are suggestions, like for example, we can cover about pediatric antibiotics for some of the GP forums, you can let us know as well. Yeah.
Okay. Andrew Chen, is there a quiz at the end of each e-learning module? Anu?
Yes, hi. So as I mentioned earlier, when you complete each module, there will be 3 questions. And then at the end of all 8 learning modules, then there will be like a final cumulative MCQ that runs for about 20 questions. I hope that answers your question.
And I know about the extension.
So again, we really want for you guys to complete it within 2 months. That also means that you can become our partner sooner. But definitely there's some trouble completing the modules. Then maybe just let us know ahead of time, because most of you so once that link is created, it will expire in the 2 months. So if we need a bit more time, then you just let us know beforehand so that we can just put in that request for you to get the extension of another month. Yeah.
Thanks. Yeah, just let us know if you really cannot complete, then we can work on getting that sorted out. Dina, there's a mistake made during the quiz and the end of the session. Okay, Dina, if any of you encounter this kind of technical issues, right, just email us quickly, and then what we'll do is we'll just verify back end and then complete it for you. And then, we just need to work with the IT team. Unfortunately, it's a separate vendor that does this. It's a visitor vendor. So occasionally there may be issues. So if there are issues, just let us know. We'll take a screenshot or something, email it to us, then back end we'll go and sort it out. Because we're hoping that everybody can start as soon as possible. How do you
maybe the compounding question on the etc.
I'm not sure. No, the sister Xiaoqi, no. Anyway, if you do know your answer, if not, we will have to check back and email. Maybe could you all email in? We can check for you exactly how it's done. Unless our nursing boss here can help answer. If you're okay. Then where can you buy
Pedialyte? Actually, I believe it's available in even like outside pharmacies, right? Like Guardian, Watson, if I'm not wrong.
They stock Hydralite. That's what I've seen before in Guardian or Watson's.
Yeah.
But again, as to where the original vendor comes from, we may have to look back and then get back to you. Yeah.
So questions are Pedialyte, condensed electrolyte.
For supplies, is it? Oh, okay.
Yeah,
then we will get back.
Supplies,
Yeah.
Okay. If I do a back slap and cast for mild undisplaced fractures, can we get a 1-week appointment? We're working on that. I think we're trying to see what we can do with direct referrals to the subspecs. At the moment, if you do a direct referral to a subspec, patients will be, or actually for chest clinics, you can still do a referral, right, Adila?
For general pediatrics, yes.
Okay.
Sure. But for subspecialties and orthopedics, I am not too sure. But I don't think so, at this point. Yeah, but
Okay.
Yeah.
If that's because we haven't worked on the subspecialty referrals at the moment. It's not been easy to start that out. Sorry, from our end, it's not been easy. So we'll see what we can do. About the subspec referrals. At the moment, you can't. If they are referred in, they will be seen as private. Unless they come in through the emergency or they go to a polyclinic and get a referral. Yeah. But 1-week appointment from a polyclinic is very doable at the moment for fracture. The compounding condensed. Will
there be a problem of huge postings spamming the WhatsApp chat group? So we did think of that. So at first we actually thought of combining the entire Paedengage into one chat group. But then because of this, we said, okay, we'll separate into the two so-called clusters. But with regards to this, at this point, we'll just have to see how things go. But the main purpose of the chat group is actually to share information in a quick manner. So if there's any updates to the guidelines or anything, any pressing or urgent problems or things like that, then that would be the best forum.
Yeah, we checked with our adult GP first friends, and they mentioned the chat groups were the best way to share information. But we will be splitting into two chat groups. Our NUH team will be managing the Western cluster GPs, and KK will be managing the other groups. But we'll see how that goes. If certainly there are problems, then we may have to figure out other ways, whether we can have smaller chat groups, etc. But bear with us as we start. This is really a start for us. We have not had any GP Plus programs, both our children's emergencies. So it's really about starting, managing, learning, and improving. Ravin says he's completed the course a few days back, but he doesn't remember seeing a completion cert. Adila, Anu, is it to be downloaded?
No. So I'll take the next couple of questions. I think in terms of the completion set, again, as what we have introduced at the start, we do have quite a few GPs that have enrolled. So we are also on our back end checking on our Wisland platform those who have completed. And once you have completed, then we will be emailing you the cert. So that we'll probably also be aiming to do in batches because there are quite a large numbers that we will have to manually do this for. But definitely, if you have completed the modules, then that will be reflected on our learning platform, and that should not get in the way of you receiving the package. For the next question, in terms of the online quiz links, so again, because the enrollment process is ongoing, so we have been starting since January. And so then again, we are trying to do this in a batch manner. So for example, for the week that you have logged or signed on to the program, then we have to forward the information to our external party to create these links as well. And again, depending on let's say in a week, if we had a lot of people sign up at that point in time, then it's also going to just cause a slight delay in terms of getting these links out to you. But definitely we're trying to do that for all the GPs that have enrolled. And it will slowly come through your emails, so not to worry about it.
We will try to push this out as soon as possible. But for those who have already received it, I think more than 200 received the links already and the accounts. Please try to finish them as soon as possible, because the moment you finish them, that's when we can officially call you our GP partner. So far I think only less than 50 have completed the e-learning modules. So do try our best to finish it as soon as possible. Then we can go ahead to put you in the groups and send you the referral badge, the brochures, the decals, etc. To make things official. Andrew, will the $50 be deducted from the CE bill once the patient is discharged using Paedengage? Yeah, so if you were to refer a patient in, the patient will be identified at triage and at the registration. And yeah, the $50 will be, so whatever the A&E fee is, will be less $50.
They have to show the physical hard copy for us to really identify them as a Paedengage referral. Then back end we will take out $50 from both the KK or NUHCE fees. Yep.
Let's see. We've answered 35 questions. Very good. Any other questions? Okay, while we wait for maybe another 30 seconds or so for any other questions, just a quick summary. Please do your best to go ahead to complete the e-learning modules as soon as you can. Once you have received the Vislearn password. And on the 28th of April, both sites, NUH and KK, will be forming the WhatsApp groups with specific GPs within the different regions. Anybody opting out of the to be put in the WhatsApp group, then just let us know beforehand, email us, and we will not put you in the WhatsApp groups. Then our mode of communication will be actually via email. So if you're opting out, let us know. The e-learning modules actually not too long to complete. So as soon as you complete them, we will mail the package to you. Anyone who's completed the e-learning module and received the package, you can start referring the patients in on the 1st of April. So the first referral officially can start on the 1st of April. And I think that's primarily what we wanted to say. And both EDs, both children's emergencies will honor referrals. If it's meant for KK and it turns up in any way, we will be happy to see, and likewise, both ways. Both of us, speaking for NUH and KK, we are new to this. So please be patient with us. At the same time, we do want to build a good network, good partnership with all of you. So we look forward to working with every one of you. Let's see, it's 2:55.
I don't think there's any further questions in the group, in the Q&A.
Yeah. And for those who had specifically asked supply-related questions, we'll get back to you directly. We will not be spamming the whole group. We'll try our best to get back to you directly. So if we do not get back to you at a certain time, please do email in to us, and we'll try our best to get back to you. It may take some time. Supply-related issues are not easy to answer. So we'll see what we can do. We will still stay on here, maybe at least for until 3 o'clock. So anyone who has any questions, feel free to ask. And otherwise, Jasmine, Adila, are we okay to say thank you to everybody there? Are we good? Yeah. Nothing further then. Thank you very much, everybody, and thanks for your time. look forward to starting very soon. Take care.
Thank you, everyone.
Thank you.
Thank you.
We will keep this live, till 3. And then after we shut the meeting, we can remove the attendee. Who might have trouble logging off. So some may be frozen, and then the team can stay back to just quickly meet for a few minutes before we leave. Thanks.
Recording stopped.